Audio recording for this meeting has begun.
Great. Sorry about that. So the recording will be made available within 1 week of this presentation. If you have questions or need technical help during the call, please utilize the chat function. You should see a box in the bottom right corner of your screen. You can private message my colleague, Neil Rana, who is listed as a host here, or myself. I'm actually listed as Sarah Stahlberg. And all questions will be addressed at the end, but we will keep a queue, so please send them our way as they come up. And I also want to flag for you that there's a box called Files, also on the right side of your screen. In this box, you'll find the actual journal article that will be presented today in case you need to download it again and reference it throughout the webinar. For our agenda today, we'll start with an introduction of our two presenters. We'll move into more information on the article background, methods involved, and results, followed by a time for discussion and engagement with both of our presenters and with you all as participants. So there'll be ample time for questions at the end. As a result of the webinar today, my hope is that you'll be able to describe the major sections of the journal article, such as the background, methods, and results, and also be able to identify the journal article's implications for your state's STD program as you listen to the webinar today. So our presenters for this webinar will be Amara Ross, who is an STD epidemiologist, and Don Diorio, a public health advisor who's also a founding member of NCSD, fun fact about Don, and a former STD program director for the state of Maine. Both Amara and Don now work at the Indiana State Department of Health. They'll be highlighting an article they are authors on entitled Social Vulnerability in Congenital Syphilis Mothers, Qualitative Analysis of Cases in Indiana, 2014 through 2016, which was published in the July issue of the STD Journal. So Don, I will let you begin.
Thank you, Leandra. This is Dawn, and yes, that is a picture of me holding a snake, for any of you who were wondering, and then you can't concentrate on anything we're going to say. This is my daughter's snake. And it tells me I probably need to have a professional picture taken. So I want to thank everyone who has called in today and anyone else who might be listening to the recording in the future. We hope that you find this useful. I want to start out by acknowledging our co-author who can't be with us to present, Karen Kroger from CDC. Karen was smart enough to have retired in January, so she, as I understand it, is off traveling somewhere and couldn't be with us. But thank you, Karen. You are here with us in spirit. I also want to say for myself, I am a CDC employee. I'm a public health advisor, as Leandra said, in the Field Services Branch, assigned to the Indiana State Department of Health STD program. But anything that's going to be presented today, anything I might say, should not be taken to be the official position of CDC. So I just wanted to put that disclosure out there. Mara is going to begin our presentation with the next slide by going over some data related to congenital syphilis. So take it away, Amara.
Good afternoon, everyone. Thank you for taking the time to join us today in this discussion of our recently published paper. As I'm sure you know, congenital syphilis is the transmission of a syphilis infection from an untreated pregnant woman to her fetus. But we also know that congenital syphilis is easily preventable if a woman is able to appropriately access medical care. And so that when we do see cases of congenital syphilis, it's an alert to us that there's been a failure to both detect and adequately treat a woman prior to a case resulting. In recent years, congenital syphilis rates across the country have been rising, and it's been particularly startling because this increase was followed by a 5-year period, where congenital syphilis cases were actually on a downward slope. So after that 5-year decline between 2008 and 2012, what we've seen is successive years of congenital syphilis rates increasing across the country. Between 2012 and 2016, the congenital syphilis case rate increased about 87%, a very startling increase. Actually, according to the recently published CDC STD surveillance report, this trend of increase among congenital syphilis cases has continued into the most recent data year, with the case rate between 2016 and 2017 increasing 43.8%. And this trend has been stated to be associated with the increase in infectious syphilis, primary and secondary syphilis stages among women both of reproductive age and women of all age groups. So similar to what we saw, or what we've seen at the national level, where congenital syphilis cases declined between 2008 and 2012, Indiana had no cases of congenital syphilis reported between 2008 and 2013. But from 2014 onward, we've actually seen between 7 and 8 cases each year, including most recently in 2017, where we reported 7 cases as well. Our number of primary and secondary syphilis cases among women has fluctuated, as you can see here, with an increase between 2014 and 2016 of roughly 227%, with our cases growing from 11 cases to 36. On any given year, we average about 9% of our cases being among women, as we are a fairly low morbidity state when it comes to primary and secondary syphilis. Next, we will have Dawn back on.
Thanks. So I guess the question becomes, if, as Amara said, congenital syphilis is 100% preventable, why are we seeing cases nationwide? So what is it that we know about what might be causing these cases? Well, we know actually quite a bit as a result of several large-scale data studies. So several researchers have looked at, for example, all birth certificates in a state, or they have pulled hospital records from many years and looked at, characteristics of the mother, characteristics of the baby, to try to determine. Mostly what they were looking for was what we call missed opportunities. So the situations where the healthcare provider failed to provide the testing for syphilis for the pregnant woman, or correct treatment, adequate treatment with bacillin. So we do know a heck of a lot about congenital syphilis based on those studies, and we also understand that there have been identified several socioeconomic and geographic differences with cases, and that congenital syphilis cases, probably not surprisingly to you, are associated with women who have started their prenatal care late in the pregnancy, or they don't have prenatal care at all, because logically it's really hard to get tested for syphilis and treated if you're infected if you are not first getting that prenatal care. But we also know more than just what happens clinically from several of the studies that have been done. And this slide presents kind of a laundry list of many of the other factors that have been shown in the literature to be associated with congenital syphilis cases. And I'll just let you take a look at some of what's up here. And you can see that not all of these items are specifically related to health care. They are more socioeconomic in nature. Amara.
All right. So our approach when evaluating our cases was to start off with our DIS case investigation notes from the mother's syphilis interviews. and also their medical history as described in the maternal record. A maternal record, just for your information, is what we use in our database, but it's actually just the top or the maternal portion of a congenital syphilis case investigation report, case report form. So we've just broken that up. This is a matter of use and protocol for our system. So anyway, while we took a look at that maternal record and those interviews, in order to determine first if established screening and treatment protocols had been followed, and then identify the common themes between our case mothers. Ultimately, we coded for factors that you see here, such as health insurance, housing instability, drug use, incarceration, and things of that nature, and also prenatal care. And so that leads us to the next section here for the results of that analysis. So what we found, just quickly going over some different demographics, is that blacks were overrepresented in our among our case mothers, as roughly 10% of Indiana's state population is black. Conversely, whites and Hispanics were underrepresented in our group at 80% and 7% of the population, respectively. None of our case moms reported Hispanic ethnicity. We also found that a majority of the case mothers had some sort of health insurance, either public or commercial. And also it was quite interesting that in 2 instances, a case mother was diagnosed with congenital syphilis twice during pregnancy. And in both instances, the cases were likely reinfected by their initial partners. So if you have any other questions here about any of our other findings, please send us something in the chat box or wait till the end of our presentation. And our next point of emphasis was evaluating the prenatal care that our congenital case mothers received. So most had at least 1 prenatal care visit during pregnancy, and it was found that their healthcare providers followed the screening and treatment guidelines appropriately in those instances. According to the American College of Obstetricians and Gynecologists, having less than 9 prenatal care visits over the course of a pregnancy is considered inadequate. So 67% of our case mothers that had any prenatal care were actually considered as having an inadequate number of visits. And then among that group, our total group, we noticed we had 2 instances of mothers having inadequate prenatal care, also going on to deliver a stillborn infant, and among our group, those in our group with no prenatal care, 1 instance of stillbirth.
Thanks, Amara. So as Amara said, we first assessed the cases to look for those missed opportunities on the part of the healthcare provider. So, for example, could we find evidence that that healthcare provider had ordered syphilis testing or prescribed adequate treatment when an infected mother was identified? And secondly, we looked for health insurance because it made sense to us to recognize that it would be very difficult for the mother to get the care she needs if she didn't have a way to pay for it. So we were somewhat surprised to learn that nearly all of our mothers, 21 of the 23 in this group, and I should say we had a total of 23 congenital syphilis cases in the period between 2014 and 2016. So nearly all of our mothers had health insurance, and we could not find one instance where the healthcare provider failed to do what CDC recommended in terms of syphilis testing or treatment. So that led us to really the research question. So what else was going on in that mother's life at the time of the pregnancy that might have been associated with the congenital birth? And it's important to point out that this is not a causal study. What we did cannot be said to, for us to draw the conclusion of, well, this characteristic caused this outcome. We identified 3 themes from reading the interview notes from the DIS as we went through the case, and we characterized these as social vulnerability, lack of engagement in healthcare, and male sex partner risk. And it's not as though one mother only experienced one of these things. Very often what we found was that several, 2 or even 3 of these themes was present for many of the women. So what do we mean by social vulnerability? Essentially, we were looking for factors that were present in the mom's life that would cause her to feel a lack of confidence or to really experience challenges in doing the day-to-day activities that I think many of us take for granted. So things like she doesn't have any money, for example. We had several mothers who didn't have jobs express that they didn't have money. Certainly we had many who had Medicaid as their health insurance source, and Medicaid certainly is a proxy for low income. We had several mothers who identified that either they themselves or their current male partner was incarcerated within the last 2 years, and sometimes it was both of them. I think that comes up on the next slide. Some drug use and domestic violence was, I misspeak, I'm sorry. Some drug use was reported, no domestic violence was reported. However, typically in studies you will find that those things tend to be underreported by people. And social vulnerability also included chaotic living conditions, including being homeless. And the last item on this slide, having no job or a bad job, the idea of a bad job is used a little bit more, I think, in the literature in Europe than it is in the United States, but it refers to jobs that are low in wages, that typically do not have benefits with them, and that the person, the employee, feels like they could lose their job pretty easily. So they're not considered real stable jobs. So what we found to try to put numbers to the social vulnerability, nearly 40% of our case moms had been homeless during the pregnancy or had an unstable housing situation, which could be they've moved several times in the last couple of months. They and their male partner and perhaps some children were living with extended family because they didn't have a place of their own, things like that. We did have at least one mom and possibly more that were in a shelter. 35% of our case moms indicated that they had a history of incarceration in the last 2 years, and this number could be comprised of either just the mother, just her male sex partner, or in some cases both of them had histories of recent incarceration. And 9% of our case mothers admitted to drug use within the last year. The next one of our coded themes was lack of engagement in health care. And this, I will say, was somewhat surprising to us and somewhat hard to understand. So what we found when we read many of the interviews is that, and we kind of looked at the timeline of, okay, the mom was diagnosed on this date and she wasn't treated until this date, or, well, she had a prenatal care visit here and the doctor did send an order for testing, but gosh, she never got that testing, things like that. So we found several case mothers who had a hard time following through when syphilis tests were ordered. And this really specifically related to when that doctor, the prenatal care provider, did not draw the blood in their own office while she was there. They had to give her an order for an off-site lab. We had many women who never did make it to that lab for those syphilis tests. Then we had several women who just were not treated after their syphilis was diagnosed. And so the doctor's office was trying very hard to reach them. The DIS, of course, were doing everything they could possibly think of to get the woman treated, but it didn't work out. And in one situation, really the only one that we found out a reason for, this was a young woman who worked at a fast food place, and she was not tested in time to prevent the case. And she told the DIS that she couldn't take time off work from her job to go to prenatal care or to get her lab work done because she wouldn't be paid for that time off, and she risked being fired because she wasn't there when she was supposed to be. And so I want to point out that that's one example of this idea of bad jobs, when people feel like they actually can't take time off of work to take care of their health care needs because they will lose their job. And the third theme that emerged from our review of these records had to do with the male partners, and I think this surprised us as well. Trying to look at, why did this mom become infected with syphilis in the first place? What we found is that almost a third of the case mothers' only risk for having syphilis during the pregnancy was from her primary steady sex partner that in most cases, I want to say all cases, but I probably shouldn't, that she believed herself to be in a monogamous relationship with. So it really came out of the blue to her to find out that she had syphilis, and then of course to have to come around to the realization that her steady male partner had infected her. What's probably a little worse for those of us in STD programs, none of these men had been identified prior to the woman's having been tested and identified as a case. So all of them, 7 of these male partners, the only reason they became known to us in public health was because of the woman's diagnosis. 2 of these male partners would not be tested, and they would not receive any epi treatment. So we do not know if these men represented new cases or not, because they refused to have any interaction with us after a whole lot of DIS work trying to make that happen. And as Amara stated in a previous slide, 2 of the moms in our group during that couple-year period were reinfected with syphilis during that same pregnancy by their steady male partner, despite all of our, best work trying to keep this from happening. So going back to the idea that congenital syphilis is 100% preventable, it certainly is, but you have to have a whole lot of things in place to be sure that that case is actually averted. So of course, women have to be tested for syphilis if they're pregnant, and women have to be tested for pregnancy if they have syphilis. Then of course, they have to be adequately treated, and that treatment has to be given at least 30 days before the birth. So if you think about it, that's actually a lot of items that have to happen correctly in a group of women that, at least in our group, seem to have great difficulty with their lives and things that were going on for them kind of outside of the pregnancy. So women should have knowledge. They should understand both syphilis and pregnancy so that they're able to think gosh, I'm pregnant, I need to get prenatal care, I know what syphilis is, I need to make sure I don't have it, etc. Ideally, the woman should have an accurate self-perception of risk, so she should be able to think for herself, well, I'm at increased risk because of my male partner's behaviors. It's really important for me to get a test, for example. She should be able to have the ability to get that health care when she needs it, basically to act on any impression that she has about her own risk. So at any of these steps, these challenges may present barriers to this care. And to alleviate that, we believe women have to have structural supports in place that will help her. So in our situation, we were very lucky with the health insurance side of it in that all of our mothers did have a payment source through their health insurance. They did have access to a medical provider, but I think in many other parts of the country, this is not the situation. Moms also may struggle with child care to get to appointments, transportation, time off work, as we've already seen. And something else that's very important to prevent cases of congenital syphilis, of course, is for those healthcare providers to be doing their part in terms of the testing and the treatment. This is, I hope you guys can see this, it's a little small, there's a lot going on. Excuse me, hang on one second. So this is something we tried to put together based on what we found, a congenital syphilis prevention cascade. And if you start at the top, what we can see is that we've got women on one side who need to be tested for syphilis, on the other side tested for pregnancy, and of course they need to be tested for both if they're positive for one. So if you think about just the very beginning of this flow chart, right there we might have some access issues, some barriers to getting this done, because the very beginning of this diagram assumes that that woman has some kind of access to the healthcare system, that she is able to leverage the healthcare delivery system. And if, I apologize again if you're unable to see the writing because it's too small, if you look at the colors, the bright green that stands out are the successes. So the two kind of in the middle, bright green, those represent not a case. So basically the woman has gone through this decision tree here, and it's been determined based on her negative tests, etc., that the infant, she's not at risk. And then the large green one kind of down at the bottom is our big success story, where a congenital syphilis case was successfully prevented. And so all of the beige ones that kind of look like dialogue boxes that you get on comics, those represent places where possible failures could occur to prevent that syphilis case. And so there's 1, 2, 3, 4. So there's 6 of those possible failure points. And as you can see going through this, there are many, many steps that would need to happen correctly in order for us to reach that goal at the bottom of having a congenital case prevented. After this paper was published, 2 great studies came out having to do with very similar looking at moms and babies with congenital syphilis. One was done by Sarah Kidd, and she also constructed a congenital syphilis prevention cascade looking at syphilis case reports and congenital case reports, where she went through and figured out how many congenital cases were averted based on action that was taken by either the pregnant woman, the healthcare provider, or public health, and she found that 75% of cases were actually averted. And another finding that came out of this was that this study identified the largest gaps in prevention among moms who delivered congenital syphilis babies was at the entry point into prenatal care, and then again between early testing and timely treatment. So this supports what I said in the previous slide about that very beginning point is rough for women to try to access the healthcare delivery system initially. And then the other study came out in the MMWR just a couple weeks ago, I believe, and they looked at New York City syphilis case reports and congenital syphilis case reports for a several-year period. And they, similar to Dr. Kidd's study, they found 88% of their congenital cases had been prevented as a result of these actions. So that's pretty great. In New York City, they found 31% of the congenital case moms did not get timely prenatal care. So that certainly is in line with our findings as well. And they also found of those who had timely prenatal care that they did have many who didn't get a syphilis test until it was essentially too late. And they also found almost half became infected after first having had a negative syphilis test, which happened with several of our moms as well. And the important point from both the Kidd study and the one in the MMWR is that most syphilis cases in pregnant women do not result in a case of congenital syphilis. So that's the really good news, I think. So again, what else might be going on that, since congenital syphilis is preventable? Well, kind of going back to the idea of, excuse me, I'm losing my notes. Going back to the idea of socioeconomic status and other social factors being really important. We have had now probably a mountain of evidence going back for a couple of decades that concludes that health outcomes are very dramatically affected by people's socioeconomic status and other social and behavioral factors. And this is commonly known as social determinants of health. And more recently, Elizabeth Bradley at Yale and Lauren Taylor at Harvard have done a lot of really great work kind of expanding this theme and looking at this more on a population basis. And so some of their findings appear here, and their argument is that in order to improve health outcomes, whatever it might be that you're looking at health-wise, that countries, states, communities should really consider increasing the amount of social spending that they do. So basically trying to improve the socioeconomic status of folks as a way to improve their health. And for Indiana, if you look at things like just our health spending, we rank close to, we're 49 out of 50 states per capita for public health funding. We also rank very poorly on the health indicators such as infant mortality, smoking, obesity, physical exercise. All of those health factors and social factors kind of play into what is going on with congenital syphilis cases. So again, going back to the MMWR article by Sanderson-Slutzker et al., they found that among their congenital syphilis case moms who had prenatal care, they identified some of these social and behavioral factors as well that were present in those moms' lives. And again, we can't say that any of these caused the congenital case, but they certainly were present and likely associated. They also had very interesting to me, they wrote about one mom who had a negative test in the second trimester, then she had an emergency department visit in the third trimester with syphilis symptoms, but nothing was done at that ED visit. And of course, when she delivered the baby, she was positive. In reviewing the literature for this paper, I found a couple of other papers that mentioned a very similar case. You know, oh, we also found this. And then I found a couple of studies, very, very few, maybe just two, that seemed to indicate that testing women who went to the emergency department for any reason, if they were pregnant, testing them for syphilis was actually a great source of case finding and did identify women who were pregnant who had syphilis and were unaware of that so that they could get earlier treatment. One of the cases among our mothers that we didn't put in the paper because I couldn't really figure out how to do it was very similar to this case mom from New York City, in that she had had a negative test in her first trimester, which according to Indiana code would tell the healthcare provider that she does not need any further syphilis testing at all. So in Indiana, if you have a negative test, you're pretty much good. Well, this young mother showed up in an emergency department around mid to late second trimester because she had a gunshot wound, and of course they didn't test her for syphilis because she was there for a gunshot wound, but then it turns out when she delivered she had a very high titer and she had some symptoms of syphilis. So clearly she had become infected. And so one of our recommendations, which I'll talk about when we get there, is really to think about doing some testing of pregnant moms in emergency departments. So in conclusion, we would have to say that if we want to prevent congenital syphilis cases, we should really focus on trying to do something with the social circumstances of the pregnant women with syphilis, as well as the traditional medical management for those cases. So in thinking about how we might, what we might be able to recommend, we kind of broke it down to what we as STD programs could do, what you all as STD programs could think about doing, what healthcare providers could do, and what maybe community agencies could do. So I would certainly encourage other STD programs to do a similar type of review of your congenital syphilis cases to really gain an understanding of what is going on in your local area that might be contributing. Some of the studies that I've read that have been done, one of them by our co-author Karen Kroger, found that in another area in another state, one of their largest problems was that women could not access prenatal care. Women who had Medicaid had a very hard time finding a care provider. I think they also found in that work that many of the doctors were not treating with Bicillin. So that's a very different issue than what we found, and so of course should be addressed in a different way. You could have your DIS collect supplemental information in order to help you understand it. It's important to try to identify males who are at risk for syphilis who have pregnant partners. So, and I know we all try to do that, but I think based on what we found, we might need to make more of an effort. And again, for us, explore syphilis testing in hospital emergency departments for pregnant women, especially those who are not in prenatal care. If you're a local health department, we hope that those folks will work with STD programs and others to try to identify women early on who might need either outreach, case management, who may have fallen out of prenatal care, try to get them back in, for example. And I think if healthcare providers, especially private healthcare providers, could try to work a little more with their male patients to find out if they have pregnant partners and make sure that those folks get treated. Another idea would be for healthcare providers, if they are unable to draw blood during the prenatal care visit in their office, they could consider using syphilis point of care test, basically the rapid syphilis test, on those women, so to try to reduce what it was that we saw, where the woman is just unable to get to an off-site laboratory for that. We've given you some of the references that we've referred to here in case you want to look some things up or read a little more. And I think before we go on to that, I just want to thank Indiana's DIS for doing a good job in recording everything. Leandra?
Awesome. Thank you so much. What a wonderful wealth of information from this article on such a important topic as we see rises in congenital syphilis in many jurisdictions. So I do want to open it up for more discussion for those who are on the line, just to talk with each other and with the presenters as well. Some of the things that you mentioned, Dawn, with how findings can be applied. You talked about healthcare providers and the community overall and STD programs specifically, kind of some recommendations that they can do. So I'm very interested to hear about what strategies your health department, for those on the line, your health department or health organization, what strategies they've really employed to address any rises, if you've seen them, in congenital syphilis in your area, and if those strategies may be similar to those that were listed as recommendations or if they've been different. I'd love to hear specifics on strategies that you've used to tackle this issue. And you can type in the chat box, you can speak on the phone line, it's up to you.
Hi, this is Robin Hennessy from New York City, and I'm also...
Hi, Robin.
Hi, Dawn. I'm also joined with Jenna Sanderson Slutzker, the author of the MMWR.
Yay! All right.
As well as our Caitlin, who is the director of our behavioral health program here in New York City. And I wanted to tell you 3 things. So the first thing I wanted to mention is that a little over a year ago, one of the things we employed, and it was something that just sort of came off of Sue Blank's head one day, which was, if we have a pregnant person with syphilis, that's a person who's got a lot of additional issues going on, given how rare syphilis is among women. And so she's like, we ought to be doing more. And so what we've set up is our social workers will now contact women who've been diagnosed with syphilis during pregnancy, follow up. They have an entire protocol of when to call, the different questions, the different things to talk about. They've elicited additional sex partners. They have very much encouraged women to get those 3rd trimester tests, and if necessary, then reconnect with our DIS, who can actually physically bring people for testing, that sort of thing. So, we had a poster at the STD conference, and, it's still in its infancy, but we're following up to see how that's going. And so, Caitlin can talk about some of those things and how those pieces are going. But before that, I wanted to just say 2 more things. The second thing is a new initiative, and Dawn, I particularly wanted to tell you because I used your paper as a justification for getting some funding for a project.
Yay!
That we're
Nice.
doing. And the project is we're teaming up with our maternal and infant reproductive folks here in the agency, and they have a Cribs for Kids program where women who meet criteria for a variety of different projects can get basically one of those pack and plays that has like a little crib insert in it.
Oh, yeah.
I mean, it's basically safer sleep that they're promoting. But then we figured out, like, if we team up with them, we can get these women into their programs. But we also kept a couple of the cribs ourselves for women who, for whatever reason, didn't want to do that program. So now we sort of have like a little incentive to try to maybe address some of the additional social vulnerabilities that they may have. And showed that the health department has something to offer besides, bothering them all the time, but, to help engagement. But then the third thing, which is the sad thing that I'm going to tell you, is that so far in 2018, all of our cases, all of them, the women were negative at their prenatal visits and then became infected. Like, we didn't find out about it until delivery. And so that's a group of folks, and that group has been steadily increasing over the last couple of years. And, you're sort of at a loss because none of these programs that I'm talking about are going to affect that particular person. So we locally, and Jenna is really heading this up, are thinking about ways of promoting more third trimester screening and coming up with some local guidance based on local data about what we think should be markers for OBs to do third trimester screening, because we have 125,000 live births and very, very, very few congenital cases. So I understand why OBs are not thinking syphilis. So we're trying to think of ways to do that. So I've done a lot of talking now. I'll stop.
Thank you for your lot of talking, though. It was so great, and I'm excited that you read the paper and you were able to use it, and I'm excited that, of course, you're a co-author of the paper I was referring to, too. I thought it was fantastic. And those ideas that come off of Sue Blank's head, I swear, are better than ideas I could have if I sit for a month and try to think about something. So I just wanted to say that, too. Yeah, I love the idea of having a dedicated social worker, follow those women. So that's a great idea, and certainly something I can put forward here to see if we can do something similar, because I do think that would help. And yeah, about your sad thing number 3, I totally felt the same way when I was looking at, oh my gosh, so many of these women were infected by either after a negative test and then, surprise, got infected, and it was a result of their male partner that they didn't feel themselves to be at risk from. And how do you intervene? Like, how do you find those men? Because, as I said, the men weren't identified first as cases. They were only found as a result of the women's screening, and it's kind of the same problem that you present of, well, the women were negative at their first test and then they were infected at delivery. My gosh, what is going on, and how do we learn what's going on there to identify those folks? I wish I had an answer. I think many of us are struggling with that. So thank you for all of that, Robin.
No problem. And I will say that your idea of testing at ED visits is an interesting one, because we've had a number of folks have sort of that, obviously the one that was in the paper, but we've even had others. So it's something we might want to.
I think, if I'm not mistaken, thinking back several years, wasn't that part of aren't EDs supposed to be doing HIV testing on everyone who walks in the doors for pretty much the same reason, in that, okay, we can't reach everybody, they're showing up at a care provider, let's get them tested. I think it's the same rationale of, holy cow, here they are, let's just test them and make sure they don't have this.
Yeah, that's a good thought.
I'm thinking about, oh, well, first, thank you, Robin, so much for that response. That was really great. And I'm so happy that, this paper was useful for you. That's awesome that, we're having these conversations, on the webinar today. And I did have a question. You mentioned OBs may not be thinking about testing, later on in the pregnancy because there may not be any congenital syphilis cases. But I was, along those lines, I'm wondering about if you all have experienced, both where you are, Robin, and Donna and Amara, with pushback from healthcare providers or even pushback from emergency departments and how that's been handled. I'm wondering where the disconnect is. I get that they may not see it as an issue, but, clearly it is given all of this research. So I'm wondering where that disconnect is and if you all have tried to tackle that with partnering somehow with healthcare providers or, with hospitals and emergency departments and how that process has gone.
So, hi, this is Caitlin from New York City, the Director of Behavioral Health. I have to say, while making some of the calls to the people who have been identified as pregnant and diagnosed with syphilis about, getting that third trimester test, we did definitely have one woman who said, my doctor said it wasn't necessary, even though they had been diagnosed, to get retested. So I do think that that does come up. And also what I think something that I think might be an issue is just, unconscious bias where, the providers just be like, oh, yeah, you're in a monogamous relationship, and not really thinking that, like, maybe this isn't a monogamous relationship, and kind of expanding or, like, going on the assumption that, well, maybe you are monogamous, but your partner isn't. Like, that connection is often not made, and that's why I think sometimes this retesting isn't happening.
I mean, I also think that the third trimester screening guidelines are recommendations, the ACOG recommendations, the, CDC, USPS, PF. They don't feel very strong. They're squishy, and they don't tell you what does high morbidity mean. What does, what are these different things that they mean, so that we can even give providers very clear guidelines, so that they don't have to spend time thinking about, that biases don't have to, fall in there. I mean, there still might be, but they don't. I mean, I know that, the overwhelming majority of our births are not congenital births, and an overwhelming majority of the people who are pregnant are probably in fairly monogamous relationships and are not at high risk. So rather than making sort of the provider have to inquire of each individual person, overwhelmingly not necessary, if there could be better, clearer guidelines.
Yeah.
And I like the idea of what Texas has done recently, which is they have moved their delivery, their health code had required testing at first prenatal visit and then at delivery, and they moved their delivery to third trimester, and then you only test at delivery if you didn't get a third trimester test. And they started doing that recently, so it would be interesting to see how that plays a role.
Yeah.
That's now across the board if you're
in
pregnant.
Texas, yeah.
That's great.
Yeah.
Thank you. Jillian typed in the chat box and said she's at the Oregon State STD program, and they found that there are gaps in syphilis awareness among community providers as well as local health department staff who haven't had experience with syphilis since it's been relatively rare. The STD epidemiologist and herself as the STD nurse, they'll be holding a congenital syphilis webinar next week, and then scheduling quarterly calls to improve case management and clinical management, which I think is awesome, Jillian. Thank you. And she agreed that syphilis testing in the ER is an excellent opportunity to detect and treat, but as with HIV testing, the other priorities in an ER setting usually preempt any testing unrelated to the presenting cause. And it would definitely be challenging. I definitely agree. It's something that was, brought up earlier about, testing with the woman that came in for the shotgun wound. Obviously, that wound was the priority, and the testing wasn't necessarily there. So, seeing this, seeing that example, just that example, can show how it can be really challenging to really detect and treat in ED settings. So I definitely understand that. Thank you so much again, Jillian, for that response. I appreciate it. And just in the interest of time, we are at 1:01 p.m., and I want to be respectful of everyone's time. I do have all of the presenters' contact information on this slide as well as mine at NCSD. I want to give a special thank you to Amara and Don just for your time and just contributing your knowledge to this webinar today. And I want to thank those who attended as well. Again, like I mentioned before, this is the third installment of the Journal Club. So I appreciate the engagement with the presenters and the questions that you all asked. In the chat box, my colleague Neil Rana also posted a link to an evaluation. I please ask that you fill that out to inform future webinars. You will also be led to that link. Once I close out the webinar, you'll be automatically redirected. But with that, I just want to say thank you. I'm so sorry to I feel like I'm cutting the conversation short. But again, I want to be respectful of everyone's time. I hope everyone has a wonderful day, and be on the lookout for the blog related to this article next month in November, and then the next Journal Club webinar in December. Thanks,
Thank you
everyone.
so much. Thank you very much.
Have a wonderful day.
You too. Bye-bye.